Thank you for viewing this educational program. This module describes the artificial urinary sphincter for the treatment of incontinence in men. Depending on the definition and assessment method used, and the party being questioned, urinary incontinence persists in somewhere between 0.5 and 74% of men following radical prostatectomy, with an average of about 5 to 15%, and 0.5 to 1% of men following other types of prostate surgery. A severe degree of leakage is uncommon and observed in less than 5% of men undergoing radical prostatectomy. Most cases are due to an inadequate sphincter or valve mechanism. Conservative therapy, including pelvic floor muscle training, is recommended in the early postoperative period, and this may speed the return of urinary control. The majority of improvement in urinary control occurs in the first 3 months after surgery, with lesser but significant improvements over the next 3 months, and even smaller but real improvements in the next 6 months or more, up to 1 year postoperatively. With this in mind, many doctors suggest that surgical intervention to limit or cure leakage is indicated in patients with persistent severe incontinence at 6 months, and in those with a lesser degree of leakage but significant bother at 12 months. Men have 2 levels of urinary control: a so-called internal urinary sphincter, or valve, and an external urinary sphincter, which is the one we can tighten to stop urinary flow. Prostatectomy removes the internal valve mechanism so that a man must then rely on the external sphincter for control. Because prostatectomy can also weaken the external sphincter, loss of urine control, called stress incontinence, can result. Non-surgical options for urinary incontinence include protective pads and undergarments, external devices such as a penile clamp, and internal devices such as a urinary catheter. Surgical options may include the use of injectable bulking agents, placement of a sling below the urethra, and implantation of an artificial urinary sphincter. It should be noted that not all of these therapies are available in all jurisdictions, and surgical preference will vary considerably. The gold standard of treatment of patients with incontinence following prostate surgery is the artificial urinary sphincter, or AUS, introduced in 1972. Refinements of the AUS ultimately led to the production of the AMS 800 by American Medical Systems, and this remains the device in most widespread use. The artificial urinary sphincter is a small fluid-filled device that is surgically implanted into the body. It is designed to restore a man's natural urinary control mechanism by opening and closing the urethra at the control of the patient. The device is made from solid silicone elastomer and consists of 3 parts connected by tubing: a cuff, a pump, and a balloon reservoir. The cuff is implanted at either the bladder neck or, more commonly, a part of the urine channel called the bulbous urethra. The pump is placed in the scrotum. When the patient wishes to urinate, he gently squeezes the soft and rounded lower part of the pump. The pressure-regulating balloon reservoir is implanted under the muscles of the lower abdomen and is filled with sterile saline solution. This illustration shows how the device most commonly sits in the body after implantation. The AMS 800 artificial urinary sphincter is made of solid silicone elastomer, a type of rubber, and does not contain any silicone gels. Solid silicone elastomers have been proven safe in over 40 years of medical use, and in fact are one of the gold standards by which other materials are tested for biocompatibility. There have been only rare reports of adverse reactions, and no proof that the elastomer caused these reactions. Small particles from the surface of the device can occasionally migrate to elsewhere in the body, but there have been no reports of this causing any problems. Modern devices are coated with an antibacterial agent to help prevent infection. Men with significantly bothersome urinary incontinence due to abnormal function of the urinary control valve, or sphincter, following prostate surgery are candidates for an artificial urinary sphincter. Certain patients may not be considered for placement of an AUS. Patients must, of course, be healthy enough to undergo a surgical procedure. Significant pre-existing medical conditions and irreversible blood clotting disorders may make it unsafe to undergo anesthesia and surgery. Untreated or unstable scarring at the bladder neck or urethra causing blockage of the urinary tract is also a contraindication to placement of an artificial sphincter, as is an untreated overactive bladder condition. Such problems need to be corrected and stabilized for a period of time before the surgery can be undertaken. Finally, men considering artificial sphincter placement must also have good enough manual dexterity and mental ability to operate the device. It is important to have a realistic expectation of the outcomes of this surgery. The risks, benefits, and potential adverse events of this and all available treatment options should be discussed with your doctor prior to consenting to surgery. The goal of surgery is to improve your quality of life by reducing the amount of urinary leakage that you experience. While it is possible that some men will achieve total dryness, most will experience a significant reduction in leakage, down to 1 to 3 protective pads per day. It is important to note, however, that even though total dryness cannot be guaranteed, more than 80% of men are satisfied with the results and experience improvement in their quality of life. Finally, understand that the result may not last a lifetime, and revision surgery may be required in some men. Cystoscopy and bladder function tests, called urodynamics, are often performed in the workup of incontinence following prostate surgery to rule out significant scarring of the bladder neck or urethra, or significant bladder dysfunction such as an overactive bladder. As with any surgery, additional tests may also be performed depending on your health and other factors, and your doctor will advise you of these. It should be noted that no aspirin, aspirin-containing products, or medications that affect blood clotting should be taken prior to surgery. Your doctor or hospital will advise you precisely on what medications need to be stopped and when. Patients should shower the evening before surgery. They are also advised not to eat or drink anything after midnight before surgery. Your doctor may prescribe medications such as antibiotics to take before surgery and will advise you about which of your regular medications you should take. Try to get plenty of rest leading up to surgery, and on the day of the operation, please arrive early to the hospital. The AUS implantation is performed under spinal or general anesthesia. Depending on your doctor's preference, one of 2 different approaches may be used to place the device. Some surgeons make just one incision or cut in the scrotum to perform the implant, while more commonly 2 small incisions are made, one in the midline below the scrotum to place the cuff, and one in the groin area to place the pump and the balloon reservoir. Occasionally, the cuff will be placed around the bladder neck through an incision in the lower abdomen. The side chosen for the pump will depend on the surgeon's preference and other factors. The surgical implant procedure is outlined here. Once anesthesia is administered, the patient is placed with his legs up in stirrups, with potential pressure points padded. The skin is carefully cleansed and scrubbed, then an antibacterial preparation and special drapes are applied. Incisions are then made, and the parts of the AUS are placed. The different parts are then connected, and the device is then tested and deactivated. The incisions in the skin are closed with dissolvable stitches, and dressings are applied. The AUS procedure requires a very short hospital stay. Sometimes it is done as outpatient surgery, and sometimes patients will stay overnight, with or without a catheter in the bladder. Antibiotics are given to prevent infection, firstly intravenously in hospital, then pills at home depending on the preference of your surgery. Walking and normal diet may be resumed right away. It is important to note that the device will initially be deactivated, meaning no change at the beginning in your symptoms. About 6 weeks later, it will be activated by a nurse or doctor in the clinic. Each doctor will have his or her own instructions for care after the procedure. Continue to use absorbent pads until the device is activated, and keep the incisions clean and dry. Many recommend that you cover the wound with polysporin or a similar product a couple times a day. If you experience discomfort after the procedure, it is best to take an over-the-counter painkiller such as acetaminophen or ibuprofen. Most of the time this will suffice. Some doctors, however, may choose to prescribe something stronger. It is also helpful when you first get home to gently apply an ice pack to the scrotum, but do not leave it on the area for more than 20 minutes at a time, and do this only once per hour as necessary. As long as the wound is clean, you may bathe or shower normally the day after the procedure. It is normal following this surgery to have some mild discomfort in the scrotum and some bruising and swelling of the skin, which may take several days to resolve. A slight bit of blood from the wound is also considered normal. When the bruising and swelling have settled, as much as tolerated, pull the pump down into the lower part of the scrotum. Avoid squeezing the pump or the deactivation button. Your doctor will advise you about when you can return to work or other activities. Typical guidelines are provided on the next slide. It is commonly recommended to take it very easy for a couple weeks or more afterwards, and full recovery will take 4 to 6 weeks. You should avoid sexual activity, strenuous exercise, and heavy lifting for the first 2 to 3 weeks following the procedure, or longer as directed by your doctor. You should not drive until you no longer require narcotic painkillers, and you can comfortably sit for long periods. Avoid very strenuous activities, as well as cycling, horseback riding, or other activities that involve straddling a seat, for 6 weeks. Like any operation, there are certain risks that you must be aware of before surgery. During the operation, there are rare risks of injury to the urethra or significant bleeding. If the urethra is injured during surgery, your surgeon may have to forego placement of the device and bring you back at a later date to complete the implant. Infection can happen after any kind of surgery. With the AUS implantation, this risk is lowered by using antibiotic-coated implants, giving you antibiotics before and after your operation, by cleansing the surgical site beforehand, and by flushing the area with antibiotic solution during surgery. Conditions that can increase the risk of getting an infection include diabetes, a spinal cord injury, open sores or infected skin near an incision, or a urinary tract infection. Device infection that does not respond promptly to antibiotic treatment may require that it be removed, and your surgeon may try implanting a new device at a later date once the infection is cleared. General early risks after surgery include wound problems such as opening or breakdown of the incision or wound infection, and blood clots in the legs called deep venous thrombosis or DVT, or in the lungs called pulmonary emboli or PE. Later on after surgery, complications specific to the AUS include erosion, migration, or persistent pain. Erosion is when the tissue next to any part of the device is broken down or wears away. Risk factors for erosion include infection, pressure on the tissue cutting off its blood supply, improper sizing of the cuff, prior tissue damage, or misplacement of any part of the device. Migration is the movement of the cuff, pump, or reservoir within the body space away from where they were originally placed. This is a very rare event. Persistent pain related to the device is also very rare and may require additional surgery to treat. It is important to contact your doctor or other healthcare provider if any of the following occur after surgery: fever, uncontrollable pain, the inability to urinate, development of a new cough or shortness of breath, swelling or tenderness of the legs, the onset of chest pain, redness, swelling, or tenderness of the incision, worsening urinary leakage with time, or protrusion of any device parts through the skin. The effectiveness of the device wears off in 10 to 15% of patients after 5 to 10 years, due to fatigue of the device or to thinning of the urethra under the cuff, called tissue atrophy. Overall, about 30% of patients will require some type of surgical revision or reoperation in their lifetime. Common reasons for this include an infection that is not controlled with antibiotics, erosion of any part of the device, mechanical failure of the device, or loss of effectiveness of the device over time. It is important to note that having to have another operation for the AUS does not, as a general rule, impact on its high satisfaction rate. So how successful is the artificial sphincter? Long-term studies indicate that 80% of men maintain good urinary control, meaning that they require 0 to 1 pad per day to protect against leakage, and the overall satisfaction rate is 90%. there is a 10 to 15% mechanical failure rate over the long term. There are certain patients who may predictably have lower success rates, and this includes those with more severe incontinence, those who have had previous radiation therapy, and those who have already failed one or more prior surgeries. The artificial urinary sphincter can successfully restore urinary control after prostate surgery. This minor surgical procedure has a high rate of success and improves the quality of life of the majority of men undertaking it. As with all surgeries, there are important potential risks to understand, and there is a chance of requiring repeat surgery later on. Thank you again for viewing this presentation.